Adrenal insufficiency. Primary adrenal insufficiency, also known as Addison's disease, is in honor of Dr. Thomas Addison, born in April 1973 at Longbenton, Newcastle upon Tyne, and died on June 29, 1860, at Brighton. Dr. Addison is also credited with the discovery of pernicious anemia. Adrenocorticotropic hormone is a major factor in secretion of the cortisol and androgenic steroids by adrenal cortex. ACTH secretion is regulated as a balance between stimulatory effect of CRH mediated by CNS and negative feedback mediated by circulating levels of glucocorticoids. Adrenal insufficiency arises when the cortisol levels are not sufficient to meet the need of the body. Cortisol aids in maintaining vascular tone, hepatic gluconeogenesis, and maintaining glycogen. Inadequate cortisol in times of stress can lead to hypotension, shock, and hypoglycemia. Mineralocorticoid deficiency typically leads to renal wasting of sodium, retention of potassium, and reduced intravascular volume. Most commonly, it is of an autoimmune etiology resulting from chronic destruction of the adrenal cortex. Typical histological features of lymphocytic infiltration, antibodies to the adrenal cortical antigens are present in the early disease process. Patients with autoimmune adrenal disease are most likely to have polyglandular autoimmune system causing the deficiency of other endocrine glands. Several other mechanisms exist, include bilateral adrenal hemorrhage, infection, TB, CMV, histoplasmosis, metastatic disease, deposition of disease, hemochromatosis, amyloidosis, sarcoidosis, drug-induced ketoconazole, etomidate, rifampicin, anticonvulsants, and adrenocortical hyperplasia. Secondary adrenal insufficiency is caused by pituitary failure of the ACTH secretion. Etiologies include any cause of the primary or secondary hypopituitarism, exogenous glucocorticoid therapy, megestrol, which has some glucocorticoid therapy. Clinical presentations: acute adrenal insufficiency, adrenal crisis should be expected in any patient, acute unexplained volume depletion and shock, hyperkalemia, acidosis, and hypoglycemia may also be accompanying. Chronic insufficiency typically develops more insidiously. Symptoms may include weight loss, nausea, vomiting, anorexia, and postural hypotension. Increased skin pigmentation can be caused by the primary adrenal insufficiency secondary to melanocytic stimulation activity associated with ACTH. Hyponatremia, hyperkalemia may also develop secondary to lack of aldosterone. Secondary adrenal insufficiency may present with evidence of adrenal insufficiency as well as other evidence of hypopituitarism. Differential diagnosis: acute adrenal insufficiency. Various conditions can cause hypotension or shock. Chronic adrenal insufficiency, like chronic starvation, gastrointestinal disease secondary to inflammation or malignancy. Other causes of hyperpigmentation, including the drug exposures and other causes of fatigue and malaise. So the baseline cortisol and ACTH levels should be obtained in early morning. A morning cortisol level of less than 3 microgram is virtually diagnostic. A level of 10 microgram is highly suspicious, and a level of more than 18 should rule out the adrenal insufficiency except in the setting of critically ill patient. Cosinotropin stimulation test: measure the morning cortisol level, pre-test level, administer of 1 microgram dose of cosinotropin. Measure a second cortisol level 1 hour after cosinotropin administration. Normal response demonstrates a level of greater than 20 microgram after the cosinotropin. Patient with both primary and secondary adrenal insufficiency will not demonstrate appropriate response. Patient with primary insufficiency will fail to respond to the repeated administration. However, the patient with secondary insufficiency may show an increased response to the repeated testing stimulation. Further determination of the primary versus secondary adrenal insufficiency will be based on ACTH levels. High ACTH levels would be expected in primary insufficiency. Treatment include treat the acute adrenal insufficiency with hydrocortisone 50 to 100 mg IV 8 hourly. In addition, volume resuscitate with normal saline. Chronic adrenal insufficiency treatment, hydrocortisone 20 to 30 mg PO daily, typically divided into two-thirds in AM and one-third in PM. May use prednisone 5 mg PO daily instead of fluorocortisone 0.5 to 1 mg PO 9 AM. Not necessarily in patients with secondary adrenal insufficiency. Provide instruction for the period of acute illness or increased stress. Adrenal insufficiency in ITU patients. It is the acute reversible dysfunction of the HPA axis in setting of physiological stress such as sepsis, intra-abdominal or post-operative state. It is estimated that 30% of the critically ill patients suffer from HPA axis dysfunction and symptoms of adrenal insufficiency. Symptoms of adrenal insufficiency include shock, abdominal pain, fever, nausea, vomiting, electrolyte disturbances, and occasionally hypoglycemia. So, who gets adrenal insufficiency? Any patient in the setting of physiological stress, adrenal ACTH resistance, decreased responsiveness of target tissue to glucocorticoids, secondary adrenal insufficiency, the chronic steroid therapy dose dependent, certain medications, etomidate, phenytoin, and ketoconazole. So, HPA axis is composed of hypothalamus, pituitary, and adrenal cortex. So, diagnosing the relative adrenal insufficiency, diurnal variation is lost during the physiological stress. Lab assay of the plasma cortisol concentration, ACTH stimulation as unreliable in critically ill patient. Random serum cortisol varies widely in the critically ill patient and increase mortality with very low and very high cortisol levels. There is no reliable test for diagnosing the relative adrenal insufficiency. So when to start steroid therapy? Low MAP or systolic blood pressure requiring the vasopressors. Response to vasopressors is irrelevant to whether the steroid should be started or not. Improved shock reversal with low dose corticosteroid use. Responsiveness is defined as maintaining MAP of 65 mg without vasopressors and the use within 1 day. Starting hydrocortisone. Do not delay the treatment of ACTH stimulation test. Treatment in sepsis, the hydrocortisone total of 200 to 300 mg over 24 hours, 50 to 100 mg 5 to 7 days. Patient receiving higher dose of steroids have worse outcome. Fluorocortisone is a mineralocorticoid and has not been shown to help relative adrenal insufficiency. Hydrocortisone seems to have sufficient mineralocorticoid activity. No diagnostic test is reliable for relative adrenal insufficiency. Low threshold to treat the relative adrenal insufficiency in patient with septic shock. Use low dose hydrocortisone physiological dosing for a limited time. Fluorocortisone has not been shown to help in relative adrenal insufficiency. Physiological stress activates the HPA axis, which in turn increases the serum cortisol levels. The serum cortisol levels remain elevated during the stress due to several factors: reduced activity of the cortisol metabolizing enzyme, renal dysfunction prolonging the half time, and decrease in the cortisol binding globulin and albumin, which brings 90% of the cortisol. Inflammatory cytokines increases GC receptor affinity and increase in the peripheral conversion of precursors to cortisol. Thank you.